First is sort of a completely sort of self-contained project or evaluation. And given the amount of time, I took liberties in trying to present to you a little bit about what's happening in Ontario in terms of survivorship improvement. And I do actually see that some of my CCO colleagues are on the line. So we could call on them to, if you have any hard questions, you can ask them those questions. So this presentation, as you can see from the slide, actually has been presented previously. It's actually been recently presented at the Cancer Survivorship Symposium in the US. And it was around evaluating the impact of models, specifically with a bit of a focus on transition models. And most of you who know me, and I see some familiar, again, individuals on the call, and hi to everybody, know that we've been working in this space for a while now with an interest in transition to primary care in particular. And this really arose from the question, you know, are we showing impact, A, around transition models as they get put into place, and B, what's actually happening. So in terms of background, as most people on this call know, specifically around breast cancer, still across the country, the vast majority of breast cancer survivors have regular follow-up visits with oncologists for several years after treatment's completed. And the transition of follow-up care to primary has been shown to be safe and often acceptable and perhaps even preferred by individual survivors and patients. CCO has really sort of tried to move the agenda forward, and from 2010 to 2013, as many of you know, a model of care to transition survivors specifically from oncology to primary care was implemented, called the Well Follow-Up Care Initiative, and there was some investment put in place across the 14 regions and the regional cancer systems, with $100,000 being given with the proviso, I guess, that some kind of sustainable transition model be put into place. The new reality is that the majority of patients with the most prevalent cancers, with about 50% of total survivor prevalence, will be cured. And the management of other comorbidities after cancer is critical to optimizing the quantity and quality of life. And, you know, as an oncologist, again, you know, I feel pretty strongly that that's not particularly well done within our cancer systems. So just in terms of thinking about how we got here, as many of you know, this starts, and particularly Cancer Care Ontario, starts with the development of best practice guidance through evidence. And a PEBC guideline around models of survivorship care was completed. Now, I guess it was in 2013. A number of people, again, on this call were contributors to that, which really allowed, you know, the formation of the evidence base to inform this next move to trying to support transition models. And the transition model initial project, where we measured just how many people from which regions were transitioned, was published in the Journal of Oncology Practice. And that laid the groundwork to this. And to date now, there are probably even more than 10,000, but as part of the original project, just over 3,000 breast cancer patients were noted to have been transitioned across the various different regions. And there was quite a bit of variable, sort of variable reporting of transitions. And what was important across these transitions as part of these projects is that individual participants agreed to be studied, if you will, you know, subsequently in terms of reporting on, you know, basic parameters about what happened in follow-up studies as well. And that's really what constitutes what we're going to report on today when we looked a little bit more closely at those individuals who transitioned. And you can see here on the slide that there was, like I said, you know, sort of variable numbers of individuals being transitioned, with some areas to remark on, for example, Champlain, and I think Robin's on the call, Robin Marash. So it was in particular already well underway here. So you can see that places that were already doing this really kind of ramped it up, whereas some other regions were really just sort of starting out. And a lot of this was based on the fact that there was good evidence that it was safe, that it appeared to be effective in breast cancer for well-selected individuals. So we know that survivorship models can often incur higher costs by providing the same outcomes, and may in fact not be cost effective. So that's, although we assumed the transition to primary care should be cost effective. And if you look at it from the perspective of the cancer system, if individuals are moving out of the cancer system, the cancer system may say that that's cost effective, but of course that doesn't take into account what happens, broader at the health system level. And it could be that there might be higher costs because of increased use of diagnostic testing, visits with physicians, a redistribution of visits. So really what we wanted to try to determine was, can we understand what the actual health system impact might have been of transitioning individual patients, other than just noting that people transitioned away from the cancer system to primary care, and maybe we're having fewer visits with oncology, but we didn't even know if that was true. So what we wanted to do is compare the health system resources and costs used by women in the well follow-up group and try to do it in a comparative fashion to try to identify some controls. So what we did was we actually managed to set up a comparative study using propensity score matching. So cases, i.e. individuals who are identified as having been exposed to transition, were identified from the well follow-up initiative, while controls had to be identified from the Ontario Cancer Registry. We chose an index date on the control side of the transition date of a matched case. We hard matched on the precise year of cancer diagnosis and living in the same region, but used propensity score matching to select a control for each well follow-up visit. And I will admit that I am not a methodological expert in propensity score matching. This was done through ISIS and through the essentially the PI of this particular project, who is Nicole Mittman. And the propensity score of being in the well follow-up group was estimated using logistic regression variables with, it's a probit methodology, including things like age, the region that they're in, using some estimate of socioeconomic status, the comorbidities through the ADG score. Some people will sometimes use Charleston, but I think increasingly now the ADG score is being used, as well as a resource utilization band, which is some measure of what the tendency is for resource utilization for an individual is prior to an incident date, as well as we talked about the year of diagnosis, cancer stage, all as predictors. And the whole purpose of this is to try to create two groups that look as much alike as they can, through this, in a way, conceptually, it's like trying to set up a comparative trial. And some people say that it's like trying to do it like a randomized control trial, but of course it isn't, and we can talk about that in the limitations. So we used administrative. We basically used all the linkable data sets that were available through the ISIS core data repository, as well as the cancer registry. And this was housed and occurred through the Institute of Clinical and Evaluative Sciences that collects population-level health data and conducts data linkages specifically for research purposes. And in Ontario, we obviously use the Ontario Health Insurance Plan, or the OHIP numbers. That's the way to link. And we used this to then tabulate and subsequently analyze healthcare resource utilization and costs mostly through billings. And you can do this essentially by visit interactions that are coded through OHIP. We also tried to look at resource utilization through the physician visits, which included all and any physicians that are identifiable through these data holdings, that included primarily medical and radiation oncologists, as well as primary care providers, surgeons, radiologists, as well as internists and hematologists, because in some settings, those are the individuals who will see these patients. We also tried to tabulate emergency department visits, as well as diagnostic imaging scans, including CT, bone, mammography, MRI, etc. So in terms of the analysis for costs and looking at outcomes, a descriptive statistics were used to describe the annual cost using an ISIS costing algorithm, which is a validated algorithm. At this point, it's tabulated in 2014 Canadian dollars, and it included tabulation of the annual number of visits and the annual number of scans. Data is summarized as frequency as proportions to describe specific health resource utilizations by cases and controls. And because of the fact that individuals, there was also a censoring procedure for individuals who appeared to have a reoccurrence or who died. So individuals may not be resident in the cohort for a full year. So there was an adjustment made for resident time in the cohort, basically for the number of days that the individuals were in the cohort. And Kaplan-Meier curves were used to describe survival between the two cohorts, because that's an outcome that's considered to be an outcome of importance by providers. So, what did we find? This table basically shows the demographics, the basic demographics of the two groups. So what you'll see here is in terms of the number of cases for whom we could find controls, there are about 2,300. That's a pretty big cohort and obviously is going to give us quite a bit of power. There really were no significant differences between the groups in terms of age, stage, the ADG score, resource utilization, and socioeconomic status. So they the matching basically seemed to work, at least at a high level. In terms of follow-up, the total number of months of follow-up was similar between the two groups, and it was just over 2 years. So again, a first sort of caveat in that this is not long-term follow-up. In terms of months from diagnosis to the index, it was around 5 years, which again is showing that this is not about an early discharge cohort, and again makes sense because when these pilots were put into place, a lot of individuals were identifying survivors that had been coming to the cancer clinics for long periods of time. And there were individuals that had been seen in cancer clinics, as people know, for indefinite periods of time, up to 10 years. So this still seemed to be about the time that most oncology practices were comfortable in transitioning people. Often that represented a period of time after completion of endocrine therapy, which at the time was recommended to be 5 years for those people who were eligible. In terms of the development of subsequent cancers after the index date of any cancer, it was relatively similar between the two groups. Again, this was not necessarily breast cancer. This could be most of these were probably recurrences, but you can see that it was relatively low, so a fairly healthy group. In terms of individual survival over that period of time, it was quite high, but interestingly was different between the groups. In terms of the cases, individuals who were transitioned, it was about 3%. In terms of controls, individuals who were not transitioned, i.e. stayed resident within the cancer system, it was 6.7, and that was statistically significantly different, which is kind of interesting. On this next slide, this tabulates annual visits to physicians. So this is the mean and median number of visits per person year. So you can see that it was quite similar between cases and controls for things like ED visit. What was interesting is that it was not significantly different between cases and controls. So in terms of individuals being transitioned to their primary care providers, interestingly, numerically, it was at a median, it was the same. At a mean, it was a little bit lower for cases, i.e. people who are identified to transition. No differences for surgery or other specialties. Importantly, the mean number of medical oncology visits was lower in the cases group, which reassures us that individuals were actually being transitioned here, so 0.39 versus 1.29. For medical oncology, less so for radiation oncology, although most people by this time are not routinely seeing radiation oncologists, so not surprising that those numbers were low. And the median was low because, again, the cutoff was 1 or lower. That's why the median came out at 0. And then in terms of radiology visits, we're mostly about radiology testing. No significant difference between the groups at about 3 per year. Excuse me. Couldn't avert that. Interestingly, when we looked at the number of scans per person year from index year to follow-up, we saw some interesting trends. The cases, i.e. individuals who were transitioned, are in blue. The controls, individuals who were not transitioned, are in red. And as most of us on the call know, in terms of routine surveillance, The only recommended test is a mammogram for individuals with an intact breast. And what you'll see on this chart, in fact, is that, if I can pull this up here, that there were actually more mammograms done in the individuals who were transitioned to primary care than individuals who stayed resident in the cancer system. And in fact, for all the other tests, like CTs, bone scans, MRIs, and other X-rays, it was higher in the groups of individuals who stayed resident within the cancer programs, which is an interesting observation. And that's really what I think drove the physician visits, and the imaging are what were found in difference in costs. So at a crude level, when tabulating total costs per person year between cases and controls, there was a significant cost difference of around $4,000 as a mean cost. But this data was actually skewed. And in fact, some of it was driven by the fact that there seemed to be a significant difference between cases and controls in terms of costs around long-term care, which we're not really able to explain, and in fact we still have to drill down on. But when you actually look at median costs and take that out, because again it didn't really make much sense, there remained a cost differential of a few $100s, mostly driven by physician costs here and by visits to institutions, particularly the emergency room, which is pretty interesting. And in terms of looking at Kaplan-Meier survival, the survival probability between cases and controls actually statistically favored those individuals who were transitioned as opposed to stayed resident, which was an interesting observation again that we can discuss in terms of how we would interpret that. And I suspect that this is in some ways reflective of an inherent bias in this group, in that despite the fact that we tried our best to do propensity score matching, there likely was some selection bias in terms of identifying individuals for transitions. And in a way, this is still a good news story in terms of oncologists hanging on to people that they had a sense that there was something else going on with, as opposed to transitioning to primary care. One could also, perhaps somewhat controversially, suggest that in fact care was better provided in the community by primary care providers. And again, individuals on this call who are familiar with the literature recognize the fact that at this point in time, for survivors who are low risk, in whom a cancer event is probably less likely, much of health could be driven by other issues and other comorbidities. And one could put forward the hypothesis that individuals that were taken care of in primary care maybe had better health outcomes because other diseases are better sort of supervised, if you will. But I think that that's pretty controversial. I think that the conclusion that I can make off of this is that at a minimum it was no worse, but it's pretty interesting. So in terms of our overall conclusions then, it appeared that there were fewer oncology visits, there were definitely fewer diagnostic scans outside of mammography, and a similar number of PCP visits. Overall, from a health system perspective, the well follow-up cases had lower overall healthcare costs. And from the perspective of the cancer system, the $1.4 million investment across the centers could potentially realize significant cost savings with transition to primary care. And the next steps were recommended to be ongoing monitoring and evaluation of survivorship models, as well as endorsement and potentially further engagement by patients, healthcare providers, and stakeholders. And I think this was a pretty important study because this is a real-world study that was really attempting to examine what could happen in a comparative fashion with a fairly large group of individuals that showed at a health system level that there really do appear to be lower healthcare costs without increased utilization. And these results have already been submitted to inform policy on Ontario as well as other regions around implementation of these models and guidance around evaluation. Because again, particularly in models of care research, it's very hard to do randomized controlled trials. They take long periods of time. There is less and less funding available to do these types of trials. So doing these types of comparative analyses are probably quite important, although recognizing that they're quite limited. So again, in terms of an acknowledgement up front, this was led by Nicole Mittman with a number of individuals from Cancer Care Ontario, from the Models of Care Group, HASMIC, Beglarian, as well as Julie Gilbert from the Regional Programs Evaluation. Steph DeRossi and Grace Kim were intimately involved, and the individuals from ISIS and beyond. And obviously, acknowledging the participating centers, and most importantly, the survivors who agreed to continue to, if you will, be followed and to give us some further data. So that was the sort of my initial proposal or submission to Mayan and to Jennifer. But what I wanted to do is roll this into a little bit about what's happening in terms of policy in Ontario. So we're now moving a little bit away from research towards implementation, and to put in a little bit of a plug for the Survivorship Care Improvement Project, which is a provincial quality improvement initiative that continues to build on this work. So what I want to do is, in the next couple of minutes, is provide an overview of this project, and then again share a little bit of some of the preliminary findings, and recognizing that some of these findings are now being shared with the regional programs in Ontario, but recognizing that this is information in evolution. So these slides at this point are for for us to look at, to think about a little bit, but are not for distribution. So the Survivorship Care Improvement Project really builds on the work that you've heard me describe before, with a vision for cancer survivors to receive high-quality follow-up care in the most appropriate setting, with targets about patients or survivors to be well-informed and receive high-quality care, for providers to be engaged and facilitate high-quality follow-up care, and for healthcare utilization to be optimized. And that operates through the development of models of care, which is a lot about what you were seeing today, but also creating tools and resources to better enable providers and patients to feel confident that this is a system that is patient-centered and built on best practices, as well as to inform system levers, because if we're going to be asking more of primary care, the recognition is that probably has to be recognized in the provincial funding models as well. So by doing it in a more explicit nature, it allows the system to look at whether or not there needs to be a shift of resources. So there is a document that's being developed in Cancer Care Ontario through the Models of Care program to look at recommendations around models of follow-up care that incorporates this information that we're generating. And there have been, this slide is really just to summarize the fact that there has been extensive engagement through a variety of different levels, including patient and family advisors, the regional primary care leads, because in Ontario there are primary care providers that specifically give time to the cancer system, as well as the leads of the clinical leads of the various different programs at Cancer Care Ontario, and the regional vice presidents. And there are a set of recommendations that have been developed around follow-up care planning that incorporates some of this evidence, more specific guidance around surveillance, because we're now moving into the issue of tabulating surveillance testing that's done to see if, to evaluate whether it's being done in concordance with guidance, and in the era of choosing wisely, being able to tabulate whether there appears to be testing that should not be done that's being done. Obviously, surveillance it goes beyond surveillance testing and communication of results, but also assessment and management of the medical and psychological latent long-term effects and toxicity management. And there are individuals on this call who are expert in that, and continuing to do leading research in that area. Recognizing that prevention and health promotion in this population is incredibly important, and for well-selected low-risk individuals, as we've talked about before, outcomes are driven by things that are maybe not directly related to the cancer diagnosis, but making sure there are mechanisms in place to continue to manage consequences of cancer, and making sure that there are communication pathways. So in terms of developing tools and resources, I think that we recognize that there's a way that we need to go beyond the current sort of guidelines. And in fact, one initiative in Ontario is to take the PEBC guidelines, which are incredibly rigorously developed documents, but very comprehensive, and some people would argue dense and perhaps a little bit impractical for day-to-day management, and developing evidence-based summary tools specifically for patients and providers that can work, with, as sort of a face, if you will, to these documents, so that there's ongoing work in that regard. But the other aspect of this is to continue to measure data and build on some of the work that we've done, for example, in the evaluation that I've given you. And I think keeping track of patterns of follow-up care, concordance with follow-up guidelines, and trying to measure the patient, caregiver, and provider experience in an ongoing fashion at a health system level and take it beyond the pilot. And that's really what we've done in Ontario now, is we've actually extended now to try to develop a survivor cohort of individuals that can be studied, if you will, in the long term. And there's been extensive work now over the last year and a half with in informatics, and Munaza Chowdhury is the lead in informatics that's really taken a lead in doing this, in developing a survivor cohort that can now be studied in terms of quality initiatives and performance management. So that there has been a cohort of over 400,000 cancer survivors across diseases in Ontario in 2016. It's an interesting methodology that's continuing to evolve, but this is a prevalence cohort. So there are people that are individuals year on year that are going to be added to this group and taken out of this group, depending on whether they obviously continue to survive and have no evidence of reoccurrence. And they're complex algorithms that have been put in place to try to accommodate, to try to account for recurrences or not. But at a high level, this cohort appears to reflect what we would expect in terms of the proportions of the most common cancers as well as the age-sex distributions. Our preliminary observation, and this is, we've now got sort of 6 years of continuing information on this on this group, that about a third continue to see a medical oncologist into their 5th year of follow-up, and about a quarter a radiation oncologist. But there is significant variation, and that's where the story can get interesting. The distribution across the 14 health regions reassuringly sort of maps against the distribution of overall populations across these, with the sort of the biggest being, these are the GTA, this is Hamilton, which is the 2nd or 3rd largest by population. These are the more rural, so that's northwestern Ontario. So from a validity point of view, it seems to map out. And in terms of the age distribution, that also appears to be appropriate. And in terms of the distribution of cancers in a survival cohort, again, the distribution appears to be what we would expect, and we're validating this against our overall expectations, knowing what survival looks like for these groups, as well as CCS, Canadian Cancer Society data as well. And just to give you some insights, again, as a bit of a validity check, not surprisingly, a group like lung cancers make up a very small proportion. So we know that lung cancers, for example, generally as a group have fairly poor survival, but we are going to be able to look at a survivor cohort, for example, of lung cancer patients, which is pretty unique here. So what are some of the things that we can do? Well, at Cancer Care Ontario, we can start mapping out and looking at what are the visits looking like over a period of time. So this is across the 14 health regions, looking at the proportion or the percentages of breast, colorectal, and prostate cancers. This is a quality outcomes indicator for 2010, looking at what proportions were visiting a primary care provider in the 6 months after treatment, suggesting sort of early engagement over a 3-year process. So you can look at that by region, and that's what some of our initial quality outcomes look like. And you can see that they're fairly consistent. And thankfully in Ontario, we're fairly high, about 90%. But what we found with this cohort is that there's some interesting variation in terms of how frequently are individuals being seen. So this is data not for circulation. It was part of our initial data. And part of this is, and you can see that it's anonymized now, so you don't know which region this is, but these are the 14 regions. And this is in breast cancer survivors looking at a period of time about 2 years after completion of therapy, and there's an algorithm to define that. And these colored bars represent whether no visits have occurred, 1 visit, 2 or 3 visits have occurred. The gray bars are individuals who have had no visits, i.e. have been transitioned. So you can see that we vary from regions that have a lot of people being transitioned early to some where there's nobody being transitioned at all. And as well, within this grouping, there are quite a bit of variation between individuals who are being seen once a year, twice a year, or 3 or more times. So this is not meant to be interpretive at this point, but it's just information to sort of look at. And in fact, that we can see, for example, when we map this over time, this is for breast and colorectal cancer survivors by medical and radiation oncology. You can see when we look at our survival cohort, you can see that this does decrease in the years after completion of therapy. But it does continue to plateau. But this is one way of continuing to look at what's happening in this population. And when different initiatives are put in place, try to do things like time series analyses to find out, particularly around patterns of care, what's happening. And more recently, what's been happening, and I can show this to you because this is now actually data that has been distributed to the regions. Regions are now being given outputs looking at what the proportion of visits there are. This is breast and colorectal cancer survivors who have at least 1 visit with a medical or radiation oncologist in their second follow-up year as sort of an early snapshot. And on these graphs you can see, so these are breast cancer survivors across the different health regions. This is the Ontario mean, 49% of individuals continuing to have at least 1 medical oncology visit, 22% at least 1 radiation oncology visit. But you can see how wide this variation is, with regions having 74% on one side, 16% on the other end for medical oncology, between 60 and 3% for radiation oncology, and then for colorectal cancer survivors, again, you can see these distributions as well. So again, the whole issue here is to not interpret, but the first observation is to observe that there is quite a bit of variation, and from a quality improvement perspective, observing variation means that there's got to be something more to this story, and we need to start exploring a little bit and engaging individuals. So some of the concluding thoughts for me is to show you how research has basically informed policy and is now coming into implementation. This change is slow and incremental, and everybody who's on this phone call who's been in this field knows this. What I've shown you is now about 7 years of work, but we are starting to come into the realm of performance measurement. But the other thing that I've shown you is we started, even as hard as this work has been to do, and it has been incredibly hard to do, and again, I can't say enough about the team, specifically at Cancer Care Ontario, in terms of what they've been doing, mostly about getting this work out, but also continuing to be engaged with researchers as well as patients and policymakers all the way through. But despite the fact that this has been hard, the easy work is the counting work. And the hard work is to try to figure out other quality dimensions, because quality is not measured in visits alone. Quality is about what happens at those visits, as well as what's happening in terms of other activities, understanding what patients' experiences are. And I think that we have to recognize that that ongoing work is important, and that's some of the work that individuals on this call are doing, and for example, work that CPAC does with some of the population surveys that are being done. And this is going to become increasingly important as individuals transition away from a cancer system where we don't have a way of capturing some of these important outcomes. And I think that we do need to continue this monitoring now, both for intended as well as unintended consequences, in terms of things like testing, interventions, and management of other comorbidities. And at this point for us, particularly on this performance measurement, the next steps are around educational interventions and trying to socialize this data and using it to start a conversation when we're able to move away from anecdote and start to move towards having some data that individuals can look at and start to develop new initiatives, and new projects. So thanks very much. Those are really all my my comments. Here's my my email, and again to acknowledge that part of what I've shown you is work that really includes many, many, many dozens of individuals. So thanks very much, and I will end it there with, I guess, 20 minutes or 10 minutes left on the clock.